Okay, welcome everyone. I'd like to start this presentation with a story about Michael. Michael is a man in his 50s with a history of substance use going back decades. He was on methadone in the past, but he's no longer taking it. For the last couple of years, he's had no fixed address, and he's been smoking fentanyl, occasionally using crystal meth. He also has psychotic symptoms that are always much worse when he was using. Within a 2-month period, Michael has presented to emergency departments around the city 7 times. His presentations are usually related to withdrawal or skin infections. We've all seen Michael or a patient like Michael. Often, when he presented, he'd be extremely agitated at presentation. But on one of these presentations, the ER doc wrote him a prescription for buprenorphine at a dose of 4 milligrams, in addition to referring him to a RAM clinic. After receiving this prescription, he did attend this appointment at the RAM clinic. His buprenorphine dose was quickly adjusted, and then he started Sublocade, a monthly injectable version of buprenorphine. Michael is still homeless. He's still intermittently psychotic, but he hasn't been back to emerge in the last year. And he hasn't had any overdoses and has been able to keep himself safe. My name is Max Zworth, and I'm very glad to be able to talk to you today about buprenorphine in the ED for management of opioid use disorder. Let's first talk about opioid-related harms in Canada. The opioid epidemic is not new to any of us. We see it every day, but I think a lot of us will find the statistics around it staggering. In the first half of 2022, there were 3,556 deaths in Canada due to opioid toxicity. That's equivalent to 19 deaths every day. In Ontario, we see 7 opioid-related deaths every day, and an additional 16 opioid-related hospitalizations. And now these are deaths and hospitalizations only related to opioid overdose or toxicity. This doesn't account for the soft tissue infections, endocarditis, and withdrawal. And this problem is only getting worse. According to Statistics Canada, there has been a 91% increase in deaths due to opioid overdoses in Canada during the first 2 years of the COVID-19 pandemic. So let's talk about our role in this opioid epidemic. This is John. John is a 29-year-old male. He's seen overnight in the general ED with a fentanyl overdose. Now, I want everybody to take just 5 seconds, turn to the person next to you and share. What do you think John's 1-year risk of mortality is? So John's 1-year risk of dying, some of you were overestimating. John's 1-year risk of mortality is 5.2%. This number has been replicated in multiple studies. It's been well shown that 1 out of every 19 patients who overdose will die within the next year. Now, just for comparison, the 1-year mortality for patients following a non-fatal myocardial infarction is 5.9%. Pretty comparable. Now, we are well positioned in the ED to intervene with these patients. They come to the emergency department often. 54% of patients with an overdose have visited the emergency department in the last year. People who die from overdose visit the ED on average 9.6 times more than age-matched controls. So let's back up and just reframe what we just said. People who are seen in the ED after an overdose are at a very high risk for 1-year mortality compared to the general population. Conversely, someone who dies from an overdose is very likely to have seen an ED physician within the last year. The point is, these encounters are critical opportunities to initiate potentially life-saving interventions. So take-home number 1 for this talk is that ED visits are critical opportunities to initiate life-saving interventions for people who use drugs. But what can we do for these patients? Well, let's talk about what current guidelines recommend for the management of opioid use disorder. A 2018 Canadian Research Initiative in Substance Use guideline, which was published in CMAJ, recommends buprenorphine naloxone, brand name Suboxone, as the first-line treatment for opioid use disorder. They made this a strong recommendation with a high quality of evidence. So first, let's dig into the pharmacology of Suboxone and then the evidence behind these strong recommendations. First, what is buprenorphine? Buprenorphine is a partial opioid agonist. So it provides enough opioid agonist activity to prevent withdrawal symptoms and cravings, but with less euphoria and sedation than full agonist opioids. The second thing that makes buprenorphine useful in the management of opioid use disorder is that it has a high affinity with a slow dissociation. It binds very strongly to the mu opioid receptors and dissociates slowly, which prevents withdrawal symptoms for 24 hours and beyond. The high affinity for opioid receptors means that it's not displaced by other opioids. It blocks the activity of other opioids, and that in turn makes the use of other opioids less rewarding and reinforcing. Lastly, buprenorphine has a ceiling effect. Doses beyond 24 to 32 milligrams don't have additional effects with regards to respiratory depression. And as a result, the risk of respiratory depression or overdose is substantially reduced compared to other opioids. Finally, Suboxone tablets include buprenorphine and then also naloxone. Naloxone is there to reduce the risk of a diversion through injection. It is not absorbed when the tablets are taken orally or sublingually. It is not going to impact the action of buprenorphine. It's just there to prevent injection and diversion. Okay, so let's talk briefly about the evidence supporting the use of Suboxone for opioid use disorder. In 2014, a Cochrane review was done comparing buprenorphine to methadone to placebo for the management of opioid dependence. The population they examined was all individuals with opioid dependence, regardless of the specific substance that they used. They excluded pregnant women. Outcomes they looked at were retention and treatment, opioid use, illicit opioid use as measured usually through urine studies, use of other substances, mortality, and criminal activity. They included a total of 31 studies with 5,430 participants. Because a lot of these studies were done in the early 2000s, these were predominantly male heroin users. Follow-up ranged from 2 to 52 weeks, and quality of evidence overall was high to moderate. They found that overall, with regards to retention and treatment, buprenorphine led to greater retention in the buprenorphine group compared to placebo, with a risk ratio of 1.82 and a high quality of evidence. They also found that there was less illicit drug use in the buprenorphine group, with a standard mean difference of minus 1.17 and moderate quality of evidence. So very few studies actually reported mortality, and of those that did, the overall number of deaths was quite low. As a result, while we have high quality RCT evidence that buprenorphine increases retention and treatment, there's fairly limited evidence, at least from RCTs, regarding the effect of buprenorphine on mortality. Now, the best evidence that we have regarding the impact of buprenorphine on mortality comes from observational data. In 2018, Rochelle and colleagues published this study in the Annals of Internal Medicine. They looked at 17,568 Massachusetts adults who had survived an opioid use disorder, excluding patients who died in the following 30 days. And they followed all these patients for 20 months. Follow-up with this population was 98%. They looked at the interventions that these groups had received. 11% were on methadone, 12% were on buprenorphine, 4% were on naltrexone, and 5% were on multiple treatments for opioid maintenance. They compared this to the group of the population who was not on any medications for opioid use disorder. The outcomes they looked at were all-cause mortality and opioid-related mortality. Here's what they found. They found that when we compare buprenorphine to no treatment at all for patients who'd had an overdose, the adjusted hazard ratio for all-cause mortality was 0.63. For opioid-related mortality, we see a similar result with an adjusted hazard ratio of 0.62. As we can see from observational data, it seems that being on buprenorphine does have an impact on reducing mortality. Now, this study was somewhat controversial when it came out. One major criticism was that it doesn't necessarily address the so-called motivation effect. Patients that are more motivated to recover from addiction may be more likely to enter in and remain in an opioid maintenance program. And certainly, unmeasured confounding is a limitation of the study inherently due to it being an observational study. But I think where this article becomes useful and interesting is when you combine it with the RCT data we just talked about. The RCTs are not subject to confounding in the same way, and they reliably show that buprenorphine increases retention and treatment. Then in turn, we have this study that provides real-world evidence that those on buprenorphine also tend to have a reduced overall mortality. Now, you may have looked at that previous graph and said, well, methadone seemed to provide mortality benefit as well. Why aren't we going to talk about that today? Methadone is a talk in and of itself, but I just wanted to highlight a few reasons that we're not going to be discussing it in an ED context. When we compare Suboxone to methadone, Suboxone, for the reasons we spoke about earlier, has a between 3 and 6x lower risk of overdose. There's a lower risk of diversion, again, because of the naloxone included in the tablets. There's fewer adverse reactions and drug-drug interactions. There's a lower risk of QT prolongation, and there's greater treatment flexibility. So while there's certainly a role for methadone in the treatment of opioid use disorder, and some patients may in fact do better on it, for all these reasons, Suboxone is easier and safer for us to prescribe from the emergency department. So the evidence we looked at so far is largely outpatient or inpatient based. It doesn't necessarily make the case for prescribing Suboxone from the ED to patients with opioid use disorder. But this 2015 RCT published in JAMA aimed to address that very question. This study looked at 329 opioid-dependent adults in the ED. Inclusion criteria were that these patients had to have used non-medical opioids or heroin in the last 30 days and not currently been enrolled in an addiction treatment. This was at a large urban teaching hospital in the US. They randomized these patients to one of three groups. Either these patients just received a referral to a local RAM clinic, similar to what we would do normally for patients in our emergency department, or they received a brief intervention, like motivational interviewing, which in this case was a motivational video about abstaining from substance use. And then in the third category, they were started on buprenorphine in the emergency department and then received that referral to the RAM clinic. Their primary outcome was engagement in treatment at 30 days, which they measured by directly corresponding with the clinic or the clinician. Here's what they found. The percentage of patients who were started on buprenorphine in the emergency department and still enrolled in treatment at 30 days was 78%, compared to just 37% of patients who received a referral alone. So the rates of engagement at 30 days was double that for patients started on buprenorphine in the ED compared to patients who were just referred. That study was cited in this Cape position statement published in 2020, which suggested that patients who meet criteria for opioid use disorder should be offered buprenorphine naloxone initiation in the ED. So take home number 2 for this talk is that prescribing Suboxone to patients with opioid use disorder increases retention and treatment and may reduce mortality. So some of you may look at these data and say, okay, retention treatment is great, but is that really a patient-important outcome? Where's the strong data on mortality? And I think it's worth considering what else takes place at RAM clinics across the country. It's not just addictions counseling and titrating of medications. They're also engaging patients with social work. They're testing for things like HIV, Hep C. They're providing harm reduction. And this may be one of the reasons that we're seeing a correlation between all-cause mortality and retention and treatment. So despite all the evidence and guidelines supporting the initiation of buprenorphine from the emergency department, we are currently under-prescribing buprenorphine to our patients in emergency departments across Canada. This was a survey, a cross-sectional survey of emergency physicians that was conducted through CAPE in 2020, asking about their practices with regards to opioid prescribing. 5% of clinicians reported giving outpatient prescriptions for buprenorphine, and 7% reported frequently or always prescribing Suboxone from the ED. Again, that's 5% of respondents through CAPE said they prescribed Suboxone to patients from the ED. There was another study in 2020 in the US. They looked at physicians from 4 EDs in Baltimore, New York, Seattle, and Cincinnati, asking about readiness to prescribe buprenorphine. And only 21% of respondents said they were ready to initiate buprenorphine in the emergency department. Now, while compared to these data, our group is doing somewhat better, we also have a long way to go. I sent out a poll a few weeks ago asking about your comfort level prescribing Suboxone in the ED. We received 81 responses overall, so thanks very much for participating. Around 50% of people said they were not comfortable prescribing Suboxone in the ED, and only 35% were either comfortable or very comfortable. Our QI team was also able to run a search through Epic, obtaining data on the number of Suboxone prescriptions written from our emergency departments over a 6-month period. As you can see, in September, there were no prescriptions for buprenorphine written from the ED, and in October, there was only 1. Now, again, we're not going to be starting every patient in the ED on buprenorphine, and that's okay, but I think these data are really telling, because we know these patients are coming to our emergency department. I told you earlier that the 1-year mortality of someone who has had a myocardial infarction is very similar to that of someone who has overdosed on opioids. But no emergency clinician would consider not aggressively treating myocardial ischemia according to evidence-based guidelines. I think it's worth asking why we're falling short when it comes to treating patients with opioid use disorder. The US study I mentioned earlier that looked at physician readiness to prescribe buprenorphine also explored barriers to prescribing the medication from the ED, and 4 overall themes emerged. 1 was a lack of formal training. 2 was perceived time limitations. 3 was limited knowledge of local treatment resources. And finally, there was perceptions regarding this being outside the scope of an emergency department practice. Dr. Jennifer Wyman is the medical director of the substance use service at Women's College Hospital in Toronto and a medical educator at Medify. I asked her about barriers to ED docs prescribing Suboxone. She highlighted similar issues. She said a lack of experience and comfort is important. She said there's also a fear of causing precipitated withdrawal, which we'll talk about. She says that a lot of emergency physicians worry that it may take too long to explain and monitor the patient. And sometimes there's a misunderstanding that we need to have a special license or training to prescribe this medication, which we don't. Interestingly, though, she also said that realistically, there are barriers on the part of patients. For example, some patients may have misperceptions or hold myths or beliefs about Suboxone that make them not willing to engage. Some people may feel that it will make them sick. Some people are worried that it's going to put them into withdrawal. And to be fair, some patients may have been started on Suboxone in the past in an incorrect way, and as a result actually did go into withdrawal and feel really sick. So that's fair, and these are things that we need to address. So take home number 3 is that we can do better when it comes to starting Suboxone from the emergency department. So with our remaining time, I want to do the following. I want to dispel any misunderstandings about these barriers to prescribing. I want to provide you with an easy-to-follow approach for prescribing Suboxone from the emergency department and discuss the various options in our toolkit for starting patients on buprenorphine. So first, who should we be considering buprenorphine in? We should at least think about buprenorphine for any patient who comes in with opioid withdrawal, opioid overdose, or any complication of opioid use. We should at least think about it. Then we can evaluate them for exclusion criteria once we've thought about it. Exclusion criteria to buprenorphine include an allergy or hypersensitivity to the medication, having used methadone in the last 72 hours, inability to provide informed consent, altered mental status, acute intoxication, or an unstable medical illness. If the patient has any exclusion criteria, okay, then we're done. The patient's not getting buprenorphine today. We're going to disposition the patient appropriately, and if we're discharging them, we should be making a referral to a RAM clinic if they want it, and we should be discharging them with harm reduction supplies, including a naloxone kit at least. So let's pause and first talk about precipitated withdrawal, because as we've said, this is one of the barriers to people starting Suboxone correctly. What is precipitated withdrawal? Precipitated withdrawal is a state of acute and severe withdrawal that occurs if the initial dose of buprenorphine is given when the patient still has other opioids on their receptors. So because buprenorphine is a partial opioid agonist with a high affinity, it displaces other opioids from opioid receptors if they're still in the system. This can result in severe withdrawal symptoms due to a net opioid deficit. So to prevent precipitated withdrawal, what we try to do is we try to wait until the patient is at least in moderate opioid withdrawal before starting the drug, and we'll talk about how to do that. And an important point, withdrawal in and of itself is not dangerous. Unless a patient is really elderly, has a lot of cardiovascular or neurovascular comorbidities, in which case it can lead to complications. Withdrawal in and of itself is not a medical emergency, but it makes patients feel terrible. And what we're trying to do here is we're trying to make patients feel less terrible so that they're going to be able to engage in treatment. So in order to prescribe buprenorphine, there's 3 things we need to know. We need to know what opioid the patient has used. We need to know when they took their last dose, and we need to know their degree of withdrawal. We're going to measure this using the COW score. I'm not going to go into this in detail, but this is an 11-point scale that allows us to estimate the degree of opioid withdrawal, similar to what we do with the CWAS scale. We estimate the patient's score either at mild, moderate, moderately severe, or severe. And so in order to start buprenorphine, generally, someone needs to have a COW score of 13 or greater. If their COW score is below 13, we do have other options, which I'll talk you through. So we have 4 general options for starting buprenorphine in the emergency department. When talking to staff and residents in the department, one common sort of hesitancy I always hear around buprenorphine is that I actually rarely have patients who meet criteria for buprenorphine, because rarely do I have somebody who meets all these criteria and has a COW score of greater than 13. What people don't know is that we have multiple ways of starting buprenorphine. And so if a patient doesn't meet your criteria for a standard start, we have other options. So we can do a standard start. We can do a home start. We can macrodose the patient, or we can microdose them. I'll talk you through how to do each of these in detail and an easy to follow algorithm. Just so everyone knows, These algorithms are all publicly available on Medify's website, which is an invaluable resource for addiction management and has an entire section on toolkits for emergency department clinicians. So first, let's talk about standard starts. So to start a patient in a standard fashion, the patient needs to be in moderate withdrawal, like we said, with a CAL score of 13 or greater. It needs to be 12 hours since they last used a short-acting opioid, 18 hours since using intermediate-acting opioid, that's something like hydromorphcontin, or 48 hours since using fentanyl. If they meet these criteria, then what we can do is we're going to give them their first dose of buprenorphine in the emergency department. It's a dose of 4 milligrams sublingually. We have these tablets in our ED, and then we're going to reassess them in 1 hour. If their symptoms are improving or not getting worse, we can go ahead and give them another 2 to 4 milligrams, and we can write them a prescription to take home with observed doses of 16 milligrams per day for a maximum of 1 week. We refer them to a RAM clinic, which we'll talk about, and they're going to get their buprenorphine in daily observed doses at the pharmacy. We're also obviously going to dispense them with a naloxone kit, and what's helpful is to provide them a handout about buprenorphine, which is available on the Medify website. Oh, importantly, you don't have to keep assessing this patient every 2 hours. They just need one reassessment, and then they can be discharged with a written prescription. Now, if the patient's symptoms are worsening, then this may be precipitated withdrawal. And this is okay, we can manage this. The way we're going to manage it is by giving additional buprenorphine. If we give doses of 8 milligrams Q1H to a max of 32 milligrams, their symptoms should quickly resolve. This is similar to what we're going to do with macrodosing, which we'll talk about in a few slides. So if you have somebody who's motivated to abstain from drugs, but they don't meet your traditional criteria because they're not quite in enough withdrawal, you can actually safely do a home start. You just have to write them the prescription. And so what happens is, this is only indicated for specific patients, right? This has to be a patient who is able to abstain for opioid use for the rest of the day, can follow an instruction sheet, maybe has some support at home. But what you do is there's a sheet that I'll show you, and you allow the patient to monitor their own level of opioid withdrawal. We start the dose at the exact same way we would in the emergency department. It's just that the patients can give themselves the dose at home, and then they're going to follow up in the pharmacy for the rest of the week. So, for example, let's say you have somebody who's not necessarily a fentanyl user, but it's somebody who uses Percocet. They come to the emergency department, they're really motivated to quit, they want help. But when you ask them when they last used, they last took a Percocet 4 hours ago because they wanted to prevent withdrawal, so they don't have a CAL score of 13 yet. This person, if they meet these criteria and are reliable, you can give them this form. Again, it's available on Medify's website. And they don't even have to do a whole CAL scale. All they do is they have to check off their symptoms of opioid withdrawal. And once they meet 5 symptoms or more, then they can safely give themselves that first dose of 4 milligrams and redose themselves titrated to their symptoms. This is what the prescription looks like for a home start. So next, we're going to talk about macrodosing. Now, the idea behind macrodosing is that this is an alternative approach to patients who also don't meet standard criteria. So a lot of patients would benefit from buprenorphine, either post-overdose or in withdrawal from fentanyl, but they don't meet those standard start criteria. And the use of fentanyl within 48 hours is an exclusion criteria to starting buprenorphine safely. So the other thing is that for patients on fentanyl, if you give them a dose of 8 to 16 milligrams, because they have such a high tolerance to opioid, they're not really going to feel better on a dose of 16 milligrams. So we need to get them up to a higher dose more quickly. So the idea is if we give buprenorphine in high enough doses, then we can displace enough of the opioids in their system, but also give them enough of an effect that we're going to overcome that precipitated withdrawal quickly. Now, I should mention, so the practice of macrodosing Suboxone is not very familiar in our department, and that's okay because it's still fairly off-label. It's been championed by a group called CA Bridge in California, and there's a group of addictions docs in Timmins, Ontario, who have also championed this approach. And they've reported really, really good success with this approach, but I'll walk you through it. So the people who we should consider buprenorphine macrodosing in are either people who are in withdrawal from fentanyl use, and that's the reason they don't meet your standard criteria, or somebody who has had full naloxone reversal in the emergency department. So if they used fentanyl within 18 to 48 hours, then we can consider it. So first, we're again going to look for exclusion criteria. Next, we still want them to have a CAL score of 13 or greater, But the difference is, whereas with a standard start, they need to wait 48 hours since fentanyl use. In this case, they only have to wait 18 hours. And if they've had naloxone, you don't have to wait at all. You can go ahead and give them their dose. What we're going to do is we give them their first dose of 16 milligrams as 2 8-milligram tablets and reassess them in 1 hour. We can keep redosing them if we need to, and then we're going to discharge them with a prescription for a maximum of 32 milligrams per day. And then exactly as you would for your standard start, you're going to write them a prescription for daily observed doses of 32 milligrams daily at the pharmacy. And they're going to follow up in RAM within the next week. And finally, microdosing. Microdosing is another option we have for patients who don't meet traditional Suboxone initiation criteria. So for example, it's too soon since their last opioid use, they're not yet in sufficient withdrawal to safely start Suboxone in the ED. And for these patients, what we can also do is we can start Suboxone at small enough doses that they don't displace other opioids already in the system, which tends to precipitate withdrawal. We're going to consider this for patients who are on something like fentanyl or methadone, have continued opioid use, may not be ready to abstain, or if somebody's elderly and has comorbidities and we think they shouldn't go into withdrawal for medical reasons. So again, the advantage of microdosing is that it completely avoids withdrawal. The doses are so low that there's really no way of causing precipitated withdrawal at these doses, and it's incredibly, incredibly safe. Again, at these doses, you're also not going to cause any respiratory depression or overdose, and so again, this is a safe prescription to send patients home with. The other thing about microdosing that's useful is that if a patient's not ready to abstain, if they're pre-contemplative, then it's still safe to take Suboxone. So they can continue to take Suboxone while their opioid use continues. The problem with microdosing is that it does take a long time to achieve a therapeutic dose. And so for patients with a very, very high tolerance, it might not make them feel that much better. And for some patients, the instructions can be confusing. So it's just important to make sure that the pharmacy is discharging them with a blister pack. This is what your prescription looks like. There's a template that you can print from Suboxone, from the Medify website. And we're going to be working on putting order sets into Epic for all this. But you just write a prescription for an escalating tapering dose up to a total of 12 milligrams by day 7, dispense it as a blister pack, and then again, dispense them as a naloxone kit with their prescription. So again, it's assumed that these patients are going to continue to use opioids. But the thing is that while on Suboxone, the drugs that they're using are going to be less rewarding. And they're still going to have some relief from buprenorphine. And finally, the nice thing about microdosing is that by the time they get to a RAM clinic, even though we started them at a very small dose, then their dose can be rapidly escalated to one that's therapeutic. So this is by far our safest and easiest option for patients that we can prescribe from the emergency department. So let's back up and talk about our overall approach. So for any patient who presents with opioid withdrawal, overdose, or a complication of opioid use, we're going to consider them at least for a prescription for Suboxone, and we're going to offer it. We're then going to evaluate them for any exclusion criteria. If the patient is in moderate withdrawal with a COWS score of 13 or greater, it's been 12 hours since their last short-acting opioid, 18 hours since intermediate-acting opioid, or 48 hours since fentanyl, we can go ahead and use our standard start. If the patient is not yet in severe withdrawal, it's been, let's say, less than 12 hours since a short-acting opioid, and they have a reliable, safe home environment and are pretty reliable, motivated to abstain, then we can do a home start. If the patient is in moderate withdrawal, but it's been too soon since fentanyl use for a standard start, we can go ahead and macrodose them and quickly escalate their dose to one that's therapeutic. And finally, if their COWS score is too low, if they're not ready to stop using, if it's been too soon since the last opioid use, then we can still at least start them on a microdosing protocol so that when they get to a RAM clinic, then they can be moved to an therapeutic dose. So as you can see, we have a lot of options for starting buprenorphine, and there's probably a lot more patients who are eligible for it than we previously thought. So some practical pearls from the experts I've spoken to. First of all, we have buprenorphine in our ED. The tablets we have 2 milligram tablets and we have 8 milligram tablets. So that's easy to use for our standard start and for macrodosing. It needs to be given sublingually. So it's a good idea to communicate with the nurses that this medication does not work if it's taken orally and swallowed. Because the Suboxone tablets have buprenorphine and naloxone in them, we need to make sure that we're dosing the buprenorphine component and not writing the patient a prescription for an escalating tapering dose of naloxone. And consider calling the pharmacy to let them know what we're going to do. Now, in terms of local resources, we actually have a lot of options here in Ottawa. We know that we have the referral forms for the RAM clinic at the Royal, but there's also the RAM clinic at Recovery Care with a number of locations around the city, and they're really useful. And also, from speaking to some of the experts in the city, the Respect RX pharmacies have a lot of experience with dispensing buprenorphine, and so it may be worth sending our patients who are microdosing or macrodosing to one of these pharmacies in Vanier or Byward, because they're going to be really experienced with dispensing these drugs. So let's talk about talking about Suboxone. I spoke to Dr. Jennifer Wyman asking if there's any phrases she finds useful for bringing up the conversation with buprenorphine with patients, because as you can imagine, it can be challenging. And she said, a lot of patients have had very negative experiences with the healthcare system over time and are almost expecting to be treated with judgment and implicit criticism. It's not only the phrases we use when speaking to patients, but the language and tone used around them in the ED that's important. So regarding specific useful phrases, she said, it's often helpful just to ask them off the bat, what do you know about Suboxone? This is an opportunity to hear about their expectations or reservations. Many people, again, may have heard that it makes you sick if you take opioids, and now we can try to address that expectation. So again, if somebody is taking Suboxone and then takes an opioid, they're not going to cause precipitated withdrawal. It's only the reverse. Somebody who's on opioids and then it takes Suboxone that causes precipitated withdrawal. Another useful phrase for us is to say something like, Suboxone can help you feel a lot better. We can get it started quickly and make arrangements for you to follow up. It would help more than anything else I can give you in the ED. And if you decide you want to switch to another medication, it's really straightforward. I asked Dr. Wyman what she most wants ED docs to know about Suboxone. She had the following to say. She said, first, it doesn't need to be time-consuming. It's much less complicated than many other things that we already do. She wanted us to know that it increases rates of engagement in longer-term care. And finally, it does not have to be a commitment to long-term opioid agonist therapy or abstinence. Suboxone is useful because it can treat withdrawal, prevent overdose while somebody is taking it, and it can provide a bridge to longer-term care. Dr. Elizabeth Scholdice is an emergency physician at the Queensway Carleton Hospital and specialist in addiction medicine. And I asked her the same question. She had the following to say. She said, those first 30 days when a patient is retained in treatment can be really instrumental. We get families engaged, patients really engaged. Patients are also more motivated at this stage because of their ED visit. She said people who use drugs are often at their basic hierarchy of needs. Even if you can give people 2 days of a treatment that leads them to not be in the sex trade, not be on the street looking for drugs, that is huge for decreasing chaos in their lives. Giving them a break, that gives them the opportunity to move forward in their treatment. And she also said starting them on treatment is way more effective than just referring them because they start to feel better during those 2 days. She also wanted us to know that feeling confident caring for this population has dramatically increased her overall job satisfaction, and she finds it incredibly rewarding. So let's review our take-homes from this presentation. First, we said ED visits are critical opportunities to initiate life-saving interventions for people who use drugs. Next, we established that prescribing Suboxone to patients with opioid use disorder increases retention in treatment and may reduce mortality. We next made it clear that we can do better when it comes to supporting patients with opioid use disorder in our emergency department. And finally, as I've shown you, initiating Suboxone in the ED is easy and provides a valuable bridge to further care. In the last 45 minutes, we talked about one of the most marginalized groups in our country that has a disproportionately high risk of dying compared to most others. We can do something for this group, and we have something to help them. I'm excited to have shared with you an updated way of making it easy to start this therapy in the emergency department, and I hope that on your next shift, you feel prepared and empowered to at least initiate the conversation with patients. Next year, when we repeat the search, I hope the numbers look drastically different. Thank you to Dr. Miguel Cortella-Blanc, my supervisor and mentor, Dr. Jennifer Wyman, Dr. Elizabeth Scholdice, and Dr. Adelman Frankel for their expert input on addictions from an emergency department standpoint. Thanks to Dr. Simeon Mitchell for helping with our EPIC search, and thanks to my partner, Dr. A.L. Brickman, for sitting through all my practice sessions.